This week on the Back Table Podcast.
The final results of Destiny CRC02 were presented. This is essentially 122 patients with HER2 positive, defined as IHC3+ or IHC2+ with ISH positive, metastatic colorectal cancer, irrespective of RAS status, pretreated essentially with fluoropyrimidines, oxaliplatin, and irinotecan. There are two stages. Stage 1, 40 patients received TDXD of 5.4 versus 6.4 mg of kilogram every 3 weeks. And then stage 2, an additional 42 patients were treated at 5.4 mg per kg to confirm the efficacy at this dose. The primary endpoint was overall response rate with secondary endpoints of overall survival and side effects.
Welcome. We are recording today a session of our Back Table Tumor Board series. And my name is John Mizrahi. I'm a GI medical oncologist at Ochsner MD Anderson in New Orleans, Louisiana. And I am pleased to have Dr. Jun Gong here, and I'll let him introduce himself and what he does, and then we'll get to it.
Thank you, Dr. Mizrahi, for that introduction. And my name is Jun Gong, and I'm a GI medical oncologist as well here at Cedars-Sinai Medical Center in Los Angeles, California. Looking forward to this discussion.
Great. So today we're going to have a two-part series. So we're going to first focus on ESMO 2025, the annual Congress. The first part of our conversation is going to be focused on key takeaways in colorectal cancer. And we'll break that up a little bit. And the second part will be on upper GI cancer, so it's a gastroesophageal cancer. Kicking it off here, Jun, is a couple pivotal trials, I thought, in the circulating tumor DNA space. So specifically with colorectal cancer, I want to discuss two trials that we heard some updated data from. So one was the Dynamic 3 study and the other is the Pegasus study. So starting with Dynamic 3, which I think is a bigger study, I was wondering if you could just walk me through a little bit of the design of the study, and then we could talk a little bit about the details and what the findings, then, get into what the takeaways are and see if there's anything that's really changing our practice yet in terms of the study.
Yeah, so happy to go over the study design. I agree with you. This was a very exciting study as well as Pegasus. Dynamic 3 basically is a phase 2 to 3 randomized study enrolling patients with stage 3 colon cancer. And basically there were two components. About over 968 patients were randomized into two really different groups here. The standard of care group, patients would have treatment per clinician's choice. And then there would be a ctDNA informed group. Here, patients who had, based on ctDNA status, were assigned to two different groups and strategies. Basically, those who were ctDNA positive were randomized to undergo escalation. And there was a lot of different options for how escalation occurred. For example, if you were in the 3-month oxaliplatin group, you can get escalation to essentially triplet therapy, which is FOLFOXIRI. And then in the ctDNA negative group, you had what they call a de-escalation strategy. And here you had some options as well with a lot of different de-escalation strategies from 6 months to 3 months of oxaliplatin-based chemotherapy to oxaliplatin-based chemotherapy to fluoropyrimidine monotherapy as well. And essentially testing out the primary endpoint of 3-year recurrence-free survival across these various strategies.
Yeah, so definitely an interesting design and something that's very relevant. Like, we want to know these novel assays that can check ctDNA in this stage 3 colon cancer population is, what do we do with this information, right? We know it's prognostic, but can it actually be predictive, and can we actually adjust the adjuvant therapy based on what the results tell us? So, just some high level results is, you mentioned there were 968 patients who were evaluable, and actually looking at them, the majority of them, almost 3/4 of them, 72% were ctDNA negative. But wondering if you could walk me through some of the results that we saw in terms of recurrence-free survival and how many patients actually got oxaliplatin, which is obviously important, knowing that we're worried about permanent neuropathy in these patients.
Yeah, so I think in order to answer that question, it's really important to provide a little bit of a context. The actual escalation arm portion of the study was presented at an earlier conference previous to ESMO, and here the primary endpoint of superiority of recurrence-free survival was not met with the triplet of FOLFOXIRI versus those that completed 6 months of the oxaliplatin-based doublet. And that's an important thing to consider, because if you look at that part of that study, really only 65 patients received FOLFOXIRI as an escalation strategy, and this was at least 3 months. 69% received 4 or more months, and 48% completed 6 months of FOLFOXIRI versus 56 or 43.4% that received 6 months of oxaliplatin doublet therapy. So more on that in a little bit, but then John, to jump into what was presented at ESMO was really the de-escalation cohort here. And here, out of 968 patients, 702 or 73%, as you mentioned, were ctDNA negative, and 353 were assigned to ctDNA-guided management, and 349 to standard of care. Over a median follow-up of 47 months, the 3-year RFS was 85.3% in the ctDNA arm versus 88.1% in the standard arm. What we did see was that in the ctDNA-guided arm, this is the de-escalation strategy, you saw a lower usage of oxaliplatin-based therapy. This is 34.8% versus 88.6% with the standard of care arm. And in terms of side effects, you saw a lower grade 3 or higher adverse event rate with 6.2% in the ctDNA-guided arm versus 10.6% in the standard of care arm. And this is not surprising. You had substantially reduced chemotherapy exposure, toxicity. However, there was non-inferiority. The non-inferiority was not reached at the 3-year RFS primary endpoint. This was 85.3 versus 88.1%. But in the subgroups of clinically low risk, this is T1 to T3, N1, they commented that de-escalation outcomes were comparable to standard therapy, a 3-year RFS of 91% versus 93.2%, suggesting that this subgroup may benefit from less intensive treatment here. And so these kind of fallout of these exciting, interesting results were the ctDNA de-escalation cohort also had a degree of heterogeneity as well. 33% went from 6 months to oxaliplatin doublets to 3 months of oxaliplatin doublets. That was the most common de-escalation strategy. The next most common de-escalation strategy was 24% of those that went from 3 months of oxaliplatin-based doublet to 3 months of 5-fluorouracil monotherapy. So there's a little bit of questions here about whether this heterogeneity may have impacted the lack of non-inferiority that was reached in the primary endpoint. Again, bringing back into the original study of the escalation strategy, really having 65 patients in the arm of the FOLFOXIRI versus 56 in the 6 months oxaliplatin doublet raises the question about, was this a really adequately powered study of non-inferiority? You may know from the IDEA trials and the MOSAIC trial, you were talking about thousands of patients that were randomized to reach a non-inferiority threshold. The investigators did comment that this was not powered for adequate comparisons of non-inferiority, but more hypothesis-generating studies result instead.
Great. And I think those are excellent, thorough, takeaways from that study. I think before we go into whether any of these change practice, I think probably worth at this time talking about the Pegasus study. And then we can kind of circle back and discuss, if you think any of these are ready for changing your practice and what your practice is at this point. So the Pegasus study was a little bit different. It was a little bit smaller. It was done primarily in Italy and Spain. And this also included patients with high risk stage 2 patients, so stage 3 and higher stage 2, so like the T4 and 0 population. Using a different assay, this was Guardant Reveal. Jun, you want to tell me a little bit about the design of this Pegasus study? So it's a little bit different than the last study, the Dynamic 3 that we discussed.
Yes, you're right, John. This was a little bit different study, but also very interesting ctDNA-guided therapy, adjuvant therapy study in the Pegasus study. As you mentioned before, this was really including a high-risk T4N0 or stage 2 population in addition to stage 3. And it was mainly done in the European, Italy, and Spain sites. Another difference from the Dynamic 3, this used a Guardant Reveal assay rather than the SaferSeq tumor-informed assay that was used in the Dynamic 3. And here, basically, there were 2 groups essentially as well. Patients who were ctDNA positive got 3 months of CAPOX, and those that were ctDNA negative got 6 months of capecitabine monotherapy. At the end of adjuvant treatment, they rechecked the ctDNA as well. If still positive, then they were switched to FOLFIRI for an additional 6 months. Or if they were negative, they were de-escalated to capecitabine times 3 cycles. And then there was another side kind of branch pathway here. If initially negative, ctDNA negative, then positive, you were escalated from capecitabine to Capox for an additional 6 months. And so this was a really unique design for this kind of ctDNA adjuvant-guided therapy.
Yeah, so definitely a little bit different in the way it was done compared to the Dynamic 3 study. And, being a smaller study, again, it's hard to have too many takeaways, but why don't you walk us through a little bit what the results showed and, in terms of the patients who were positive versus negative and what we saw in terms of recurrence of those patients as well.
Yeah, so that's the key points, John, I think are, you get a lot of, conventional and modern data from studies like this. So firstly, those who had post-surgery ctDNA collected, it was positive in about 26% of patients. So this is 35 out of 135 patients. And then of those that had a liquid biopsy negative, now this is ctDNA negative, out of 100 of these patients that were ctDNA negative, 12 actually experienced relapses. So this is giving you a kind of an idea of the false negative rate here of 12% of patients, which if you compare it to the larger Galaxy study, it's largely comparable. It's around 12 to 15% of these patients are going to have a false negative rate. And so those were the initial kind of takeaways. The main takeaways, the primary endpoint was feasibility. This was essentially a 2-year disease-free rate among patients with 2 consecutive postoperative ctDNA negative results. And essentially you needed less than or equal to 14 relapses among 134 ctDNA negative patients to confirm the pre-specified alternative hypothesis of 92%. The primary endpoint, the upper CI, was 93%. So it barely crossed the alternative hypothesis target of 92%, narrowly missing the predefined feasibility threshold. However, there are some other takeaways there. After 3 months of Capox, 11 of 35 ctDNA positive patients were converted to ctDNA negative. This is 31%. So you're looking at a 31% clearance rate with 3 months of Capox. And then of those that were 23 that were ctDNA positive that then received FOLFIRI after Capox, 11 or 48% were converted to ctDNA negative or liquid biopsy negative at the time of the analysis. So this is, I think, a little bit of an encouraging data set that we really haven't seen much of, that you do see potentially a little bit more potential activity for clearing residual disease with the concept of switching therapies from essentially platinum-based chemotherapy to irinotecan-based chemotherapy when you are MRD or minimal residual disease positive, essentially.
Yeah, and I think one of the other takeaways here is that obviously we know that prognostically having a positive ctDNA post-surgery is a very negative prognostic sign. But as you mentioned, you can clear that with some adjuvant therapy. Now, interestingly, if you look at the patients of the 11 that initially were ctDNA positive that cleared it and became negative, most of those patients did go on to still relapse. So 8 of them still had relapse or converted to positive ctDNA after initially clearing it, indicating that, there could be some transient clearance that then you're getting a small enough residual disease that then declares itself later on. So I think, longer follow-up will tell us, are we really curing more patients in that setting? Obviously I think we are some degree, but not a transient clearance doesn't necessarily mean we're curing those patients.
That's actually a great point you raised, Sean. I think this also raises the question of whether ctDNA clearance, we have to define really the threshold to really consider it a valid endpoint as a surrogate, at least, for disease-free survival, which has been one of the earlier critique of some of these studies.
So let me bring it full circle here and say, all right, Jun, based on this data and your day-to-day practice, is ctDNA monitoring something you are doing? Have you historically been doing it? Does any of this data or the previous data we've seen in the last 6 to 12 months, has that changed your practice? And if so, which patients are you doing it in or aren't you? I know it's a very controversial question and there's no right or wrong answer, but just curious where your head's at here.
Now, John, that's the million-dollar question. I think it's gaining incredible popularity. I think it's important to make some caveats here that the NCCN guidelines haven't established ctDNA as a standard of care integrated into their treatment pipeline, for example. We all understand that it's highly prognostic. Whether it's actually established to guide adjuvant-based therapies, I think is still up in the air. Both of these studies that we mentioned failed to meet primary endpoints, but likely due to reduced power So I think a lot of eyes are on NRG GI008 Circulate US. This is the ongoing phase 2-3 trial. It's going to have over 1,900 patients with stage 3 and high-risk stage 2. And this was intended to be an adequately powered study. So I think this will really practice inform our practice. For now, I tend to do it on a case-by-case basis. Ideally, we try to put them on a trial or some ctDNA-based study as well, but a case-by-case basis. And if that does occur, I generally don't send for stage 1 patients. It's really these high-risk stage 2 or stage 3 patients that we discuss the option of circulating tumor DNA. But with the caveat also that patients understand that this is really prognostic right now, and we don't really have I would say a high-level established guideline of what to do with these aside from a trial perspective.
Great. No, I think that's excellent. I mean, I totally agree. I talk about the pros and cons with my patients, more so in the stage 3 setting, higher stage 2, about the benefits, the potential downsides, the anxiety that can come with it. Though we do have some data from, I believe it was the Bespoke study that showed that actually some patients prefer it in terms of anxiety levels, and they actually like having those results. But, it's like any other test. It's a case-by-case basis. We discuss with our patients. But again, not currently recommended as part of the NCCN guidelines, as you alluded to. But the tests are out there, and, I think for the right patient, after discussion, it's reasonable to consider. Moving on into a few studies in the metastatic setting is what I want to discuss next for colorectal cancer. I think kind of one we've been waiting, very interesting study, I think, was the Stellar 303 study. So this was a study, I'll kind of set the landscape a little bit and then, allow you to kind of take us home with the points here. But this was a kind of pivotal third-line microsatellite stable colorectal cancer study that was looking at using an immunotherapy-based strategy in patients who we otherwise, have not had much success in using immune checkpoint inhibitors in. So this is microsatellite stable, patients who had progressed on previous fluoropyrimidine, irinotecan, oxaliplatin, and bevacizumab or anti-EGFR, depending on their RAS-RAF status, and then also BRAF targeted therapy if that was appropriate for them. And this was a large study, 901 patients, and they were randomized 1-to-1 to getting zanzalintinib, which is a tyrosine kinase inhibitor, with atezolizumab, so that PD-L1 inhibitor, versus regorafenib, which is a standard of care for this patient population. And the dose of zanza was 100 milligrams daily and atezo 1,200 milligrams intravenously given every 3 weeks. They were stratified by a few different factors, but I think perhaps most importantly was the presence or absence of liver metastases, which we know from other studies, might indicate as a predictive measure of patients who may or may not benefit in the microsatellite stable population to immune checkpoint inhibition. And it had dual primary endpoints of overall survival in the intention to treat population, so everyone, and then also specifically in the patients without liver metastases. So that was kind of setting the stage. So you want to walk us through a little bit of what the results are, since this was our first peek to what this activity was with this regimen.
Yeah, John, thanks for that breakthrough of the study design here. This is a highly anticipated study and really gained a lot of attention at ESMO when this was presented. The initial presentation was at a median follow-up of 18 months, and the combination of zanza and atezo significantly improved outcomes, median overall survival of 10.9 versus 9.4 months with regorafenib, the hazard ratio being 0.80, and this is a statistical p-value of 0.0045. OS rates at 12 months with 46% versus 38%. And basically the PFS also showed a benefit, hazard ratio of 0.68, 3.7 versus 2.0 months in favor of zanza and atezo. The survival benefits were consistent across pre-specified subgroups, including those with presence or absence of liver metastases. And the safety profile, I think, was what we expect when you combine a VEGF TKI multi-kinase inhibitor. You saw slightly higher rates of hypertension, grade 3 to 4 hypertension rates were 15% versus 9%, for example. Slightly higher rates of fatigue and diarrhea and proteinuria of 6 versus 2%. And basically, essentially no concerning new safety signals from what we would expect from the relative agents in combination. But I think this was heralded was the first phase 3 trial showing a significant OS improvement with an immunotherapy-based combination in a treatment refractory MSS MCRC. So this was really touted as a potential new option in the refractory population.
Yeah, exactly. So I think, we're still waiting on kind of what the FDA is going to do with this. I mean, zanzalintinib does not have approval in colorectal cancer right now. It's kind of touted as maybe a next generation cabozantinib in terms of its mechanism, and has a shorter half-life, which is kind of one of the touted benefits of it over cabo. But, I think the jury's still out. I mean, there was a OS benefit, a PFS benefit, as we saw. It seemed to be there was indications it was both in the liver mets and non-liver mets patient. The benefit was pretty similar. So if it does get FDA approval, and if it makes its way on NCCN guidelines, I'm certainly interested to see what the adoption will look like in terms of that practice. But obviously, anytime we get another potential option in pretreated colorectal cancer for microsatellite stable, which is the overwhelming majority of patients, I think that's good data to have. Shifting gears a little bit, wanted to talk about a study that was done going back a little bit to the population of localized disease. And we have increasing data for MSI high patients that perhaps even in localized MSI high colorectal cancer, that immunotherapy should be used earlier, right? So there are multiple studies that show this. The one that's probably the most robust with most impressive data is the niche 2 data that was out of Europe. But what was done at ESMO, and you can help walk us through this a little bit, was a comparison of a previous study. We had the Foxtrot study, which was a neoadjuvant chemotherapy study that included both MSI high and non-MSI high, so microsatellite stable population. And there was an abstract at ESMO that tried to take patients who are MSI high from both studies and say, can we see a difference, right? Is chemo, like in Foxtrot, the way to go, or is it really using immunotherapy-based approach? And I think we got a pretty telling answer there. So why don't you walk us through a little bit of that data that was presented?
Yeah, John, this was another exciting study. Basically, from what we knew from a Foxtrot was in their initial readout, the MSI high population that even received neoadjuvant chemotherapy of essentially oxaliplatin-based neoadjuvant therapy, there was about a 70% no regression rate in those with MSI high versus MSS. And so we were already getting a signal there of, are we really benefiting patients with neoadjuvant conventional chemotherapy in that study? And what this study did was it took that population and essentially did what they call a matching adjusted indirect comparison. So they really matched the MSI high patients that were also T3, clinical T3 to clinical T4, N0 to N2, non-metastatic, mismatch repair deficient colon cancer from those that received neoadjuvant immunotherapy in niche 2. Essentially, there were 94 patients that matched up with niche 2 to the Foxtrot study. And here, as you hinted, the DFS was improved virtually. Within Foxtrot, the 3-year DFS was 70% for CT4 and 84%. Another point about this and a little bit later on. But the comparison, while the DFS for both these T3 and T4 tumors that were treated with neoadjuvant immunotherapy was virtually 100% in niche 2. And so here, I think it's important to highlight also that the PCR rates were a little bit better. One of the points I wanted to make was in Foxtrot, the cohort, the 3-year DFS was 70% for T4 tumors and 84% for T3 tumors. These are MMD deficient mismatch repair. But we would argue these patients, it should be 0, it should be 100%. You should have 0 patients progressing on a curable intent pathway, when instead there were 100% for both T3 and T4 tumors in niche 2. So I think this was really the conclusion, was that although this was a kind of a cross-trial but matched comparison, there was a statistically significant and clinical meaningful difference in 3-year DFS favoring neoadjuvant Nivo-Ipi over chemo in patients with locally advanced mismatch repair colon cancer.
Yeah, I think you're exactly right. And I think what was particularly interesting is that it's with the Ipi-Nivo in terms of the niche 2 is that patients really received 1 dose of Ipi and 2 doses of Nivo. And this was not a protracted, 6 to 12 month course of neoadjuvant immunotherapy. I mean, it was really low intensity from a time period standpoint and getting them surgery relatively quickly. And, seeing a Kaplan-Meier curve that is a completely horizontal bar is not something you see really, I don't want to say every day. I've never seen it. So this was, I remember when these data were presented from the niche 2 study were quite remarkable. And I really think our practice changing. And I think it really calls into question, even in light of the atomic data, which, was use of FOLFOX plus atezolizumab for patients with stage 3 MSI high colorectal cancer, is the question of, should we really just be doing neoadjuvant immunotherapy for these patients? So Has that made it to your clinical practice yet, or is it still something that you see just as part of a clinical trial patients? And how have you adopted that, or not yet?
I think that's a great question, John. I think it certainly has moved the needle to discussing this more and more realistically. I think at our institution, I'm sure at yours, our colorectal surgeons have been very open in discussing the prospect of neoadjuvant immunotherapy. Most of my surgeons are agreeable to that at this point. Right now, we're eager to see how the NCCN guidelines are going to reflect this as well. Currently, in the NCCN guidelines for colon cancer, if there are locally advanced bulky T4 tumors, you have a preferred NCCN recommendation for neoadjuvant immunotherapy in these patients. So I think it's certainly data like this that's moving the discussion more and more relevant these days.
Yeah, absolutely. We have a current protocol that's looking at trying to do non-operative management, actually, in MSI high colon cancer, which, I think is the next question, right? If immunotherapy works so well in the neoadjuvant setting, could you actually adopt what we do, maybe a little bit more in rectal cancer, and do non-operative management? The other thing that's tricky in this population, of course, is proper T staging, right? So a T4 tumor is maybe a little bit easier to assess on a CT scan if it's invading another organ, but, T1 versus T2 versus T3 is not so straightforward with our current modalities, right? Colonoscopy is not really going to tell you that, and CT scan is not typically going to tell you that either. And, node positivity is tough too, right? So you might get a reactive node or nodes that aren't enlarged, and then they come out and they're 6 positive nodes in pathology. So I think the clinical staging in early stage colon cancer is not quite as, easy as it is in rectal cancer. So that's another difference that we notice.
And it requires consistent MMR testing across both academic and community settings, really, to identify these patients as well.
Yeah, absolutely. I think the last colorectal cancer study, and there were a number of them, so it's hard to kind of pick out the ones that, we thought were kind of most practice changing, was kind of an updated analysis from the Destiny CRCO2 study. So this is a study that was looking specifically at patients with amplified HER2 positive colorectal cancer, and with the use of T-DXd, of trastuzumab deruxtecan and HER2. And we found some updated kind of final analysis and results from that. And I think perhaps the most important was, optimal dosing of T-DXd in this patient population. There is a little bit of discrepancy in breast versus upper GI in terms of what the right dosing is. So seeing what the right dosing is. So why don't you walk us through a little bit of the findings that were presented at ESMO from the Destiny CRCO2 study, if you don't mind.
Yeah, so the final results of Destiny CRC02 were presented. This is essentially 122 patients with HER2 positive, defined as IHC 3+ or IHC 2+ with ISH positive metastatic colorectal cancer, irrespective of RAS status, pretreated essentially with fluoropyrimidines, oxaliplatin, and irinotecan. There are 2 stages. Stage 1, 40 patients received T-DXd of 5.4 versus 6.4 mg of kilogram every 3 weeks. And then stage 2, an additional 42 patients were treated at 5.4 mg per kg to confirm the efficacy at this dose. The primary endpoint was overall response rate, with secondary endpoints of overall survival and side effects, among others. The final result, with the data cutoff of December 4th, 2024, this is the median follow-up of which had increased to 14.2 months for the 5.4 dose and 12.7 for the 6.4 dose. Essentially, the confirmed overall response rates was 37.8% for the lower dose versus 27.5% for the 6.4 dose. The median duration of response was 5.5 months in both arms, and median OS was 15.9 months at the lower dose versus 19.7 months at 6.4 mg per kg, but this being a secondary endpoint. Essentially, these results confirm that T-DXd induces clinically meaningful and durable responses consistent with their earlier analysis. They did comment that the longer median OS observed in the higher dose arm did not offset its increased toxicity burden, where there is certainly higher drug-related interstitial lung disease at the higher dose of 17.9% versus 9.6% at the lower dose of 5.4 mg per kg.
Right. So, of course, the dreaded outcome of trastuzumab deruxtecan is that interstitial lung disease. So it was about twice as high with the higher dose, so 6.4 versus 5.4. So I think that is helpful data to have and kind of supports the use of the 5.4 milligrams per kilogram dose for the colorectal cancer patients. Okay, so that's going to wrap up our colorectal cancer conversation. In part 2, we're going to be talking about gastroesophageal cancers and takeaways from ESMO from that. So thank you for listening to part 1.
thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable_onc. That's _backtable_ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.